So Dr. Zochodne has traveled down from Edmonton today just to be with us for this Neuropathy Awareness Day. He's a neurologist, he's a neuroscientist, he works out of the University of Alberta, and prior to moving to Edmonton, Dr. Zochodne was a professor here at the University of Calgary at the Hotchkiss Brain Institute. Dr. Zochodne has devoted his career toward understanding biology and the diseases of the Peripheral Neuropathy Association. He has also been a great supporter of the Calgary Neuropathy Association, right from its inception of an idea in 2001, when this organization was founded by Val Shaw-Lewis. So please join me in welcoming Dr. Zochodne.
Thank you very much, Sylvia. Thank you for inviting me, and thank you, Luann, for joining this morning. It's great to see you again. And you know, the great thing is to have someone knowledgeable about healthcare in government that's actually working to do that. So to have Luann there at the table, I think it's so important. All these things we used to discuss in our department meetings can now have a wider audience, and are so important. So it's a real privilege to come and join you this day. So thank you to Linda and Sylvia. And you're really kind of the inspiration that I find in trying to continue to work in this area. But I also like to try and convey to the younger people in the lab, whether they're graduate students, residents who are seeing neuropathy patients. So Linda, for organizing today and organizing the group. Past president, of course, Sylvia, who's come up to Edmonton for our nerd run a few times, so she's been a great advocate for doing better, understanding neurological disorders. And for my old friend, Val Shaw-Lewis, who was really pretty amazing person, a force of nature. And her daughter is here today. Val, I think I can remember the first meetings we had to start this. And as I said, she was a real advocacy force for this. I promised to tell a funny story about Val. We were into teaching medical students, and we had a sensory nerve course at the U of C, and I thought, well, it'd be great to have Val come and talk about, what's her experience of what neuropathy is like. Just give the students a real feel of what neuropathy is all about. But Val had her own ideas about it, and she came into the lecture room, and the first thing she did is point to somebody in the first row and said, okay, what's CIDP? And the poor student, having just started the course, was sort of struggling. Well, how about you? You tell me what CIDP is. And so the students were in a little bit of fear of Val from the beginning, but got to know her, and she did a great job. So it was really great to have her do that. Well, I don't have to convince this group that peripheral nerves are unique. They're not a microcosm of the brain. They have their own structure here with these small unmyelinated fibers that Luann alluded to that control autonomic function, but also pain, and the myelinated fibers. And there are a whole host of neuropathies, as she mentioned, that can target them in particular. And then if we hone down on the nerve itself, here's the myelin sheath, this lipid sheath that can disappear and cause substantial amounts of disability if you have chronic inflammatory demyelinating polyneuropathy, for example, but even in diabetes and other conditions. And so it's a complicated system, and I think, again, Dr. Metz alluded to this. The motor fibers can be involved, or the sensory fibers, or the autonomic fibers, and even among these, there are different sizes of fibers that may be involved. And that's why it's so disparate. And that's probably why it's been hard to advocate for one kind of neuropathy, and coming together as a group makes a lot of sense. We also recognize that the nerve fibers permeate everywhere, except perhaps the interior of the brain or the liver, but they're all through the body, and in the skin in particular, there are these fine nerve fibers that can grow, and they have to keep growing and be plastic and keep up with the fact that you're losing skin cells normally. So we call these dynamic and plastic fibers. Sorry, I'll back up a little bit. And you can see them here with special stains going right out through the skin. This is called epidermal nerve fiber biopsy. And we can start to do these in Canada. They've been doing them in the States for a number of years just to see, are they reduced, are they absent? But we also know that they have the capacity to grow back, which is really interesting. So there's hope for neuropathy to regrow these fibers. So we mentioned lots of different kinds of neuropathies. This person had radiation damage to her nerves. This is an old picture of someone who would have had a bullet injury, taking out a nerve, and that nerve is unlikely to grow past the knee. We don't have any therapies to get it to get them to grow faster and to grow to the proper muscles. These are the polyneuropathies, just meaning they affect multiple nerves, and many of them have what we call a dying back of the nerves from the hands and feet, and it's extremely painful at the same time. So they may have numbness, tingling, paresthesia, and some of you, I'm sure, experience this. There are types of neuropathy that can put people into the intensive care unit, and this is one type here as well, a form of Guillain-Barré syndrome, but it attacks the wiring or the axons, and they're really tough nut to get to grow back. So axon regeneration is what we're hoping to accomplish and to work on, because there are no treatments to make the axons grow better, to grow past the knee in that person. So here's demyelination. You lose these insulation sheaths on the nerves here by an antibody attack if you have Guillain-Barré syndrome, or a more chronic attack if you have CIDP. And then there's the axon damage type neuropathies as well. These come from, say, chemotherapy or toxins. They used to come from kidney failure, but I think we may have beat that one more recently, and I can explain why. I think this is just a picture of the barriers to regrowth. So here's a nerve bundle. These are intact, but this one is trying to grow back through this area of injury here. And this is from old pathology slides after World War II, but it just stops. The nerves just stop and they won't grow. So why is that? How do we convince the nerves to grow better, to get through these inhibitory areas of the nerve? Sorry about the, you may have seen this one before, but this is just to give an idea. If the nerve is damaged, it has to form these end bulbs, it has to recruit all of these cells to help it guide to grow back. But look at some of the fibers are going the wrong way, they don't know which way to go, and you may not get enough fibers as well. So there are lots of different ways to try to address this. I have a young new colleague who wants to study nerve damage in, of all things, zebrafish, but it's a wonderful model for identifying new molecules, and if you can get those nerves to grow, next step is the mouse, the next step may be the person in a trial. This is the challenge. The nerve is transected, it has to grow back, has to send its fibers, they have to know the right direction to grow. And we sometimes see that in somebody with Bell's palsy, which is a neuropathy of the face that causes paralysis, and most of the time the nerve grows back properly and people recover after a few months. But other times the nerves go the wrong way, and we notice they innervate the wrong muscles. So when someone blinks, their mouth moves, or when they move their mouth, the eye blinks. So there are all these issues about going the right direction, and here's just some examples of fibers reluctantly trying to grow. They're really hesitant. They don't like to grow. Some will grow and start forming myelin. Others are kind of sitting around waiting for something to happen. And at the very tip of the growing axon is where the action may all be. This is called a growth cone, and they're really fascinating to watch. They look like a hand trying to grow through these inhibitory environments, trying to advance their processes. And there's a whole series of molecules on them that either tell it to stop, or retract, or to advance. And so if we can harness these, we may be able to get some neuropathy treatments that act locally instead of taking a pill to use it in the skin, for example, to get those axons to grow back. So these are just some new ideas. Here's a break that exists in nerve cells, and it's called RhoA, and it causes the nerves to retract and not to grow. So if we can use a RhoA inhibitor, we might get the axons to grow back. And some of these have been tried in spinal cord disease as well, spinal cord injury. So the way we do things is we try to test the nerve cells in culture and see what makes them grow. And here's RAC, which opposes Rho and makes these nerve cells grow. The next step is to try it in a model, in an animal, or it could be a zebrafish. And so if you activate RAC, you get, this is normal nerves with all the myelinated fibers. Here's one that hasn't had any treatment. So we have less than a third of these fibers are still there. But with a RAC activator, you can improve things. So we have to start thinking about how to translate these to people. And here's skin fibers here. Those are these epidermal fibers I showed you, normal. Here's someone who's had an injury. There's nothing growing back. This one, there's nothing growing back. But here's this RAC activator. We're just starting to see regrowth into the skin here. So, and that's with local treatment, not with taking a pill. So there's a number of these molecules. So I'm just trying to convey that there is hope. We mentioned this RHO-A, but there's a number of them, and we've worked on a number in our lab, and many places around the world are working on them as well. Here's some further ones. And the final one I'll just mention is this one, that one of your colleagues and I were just talking about. It's early in the stage, but pirenzepine is an old drug that they've repurposed, and it seems to help with diabetic neuropathy as a topical treatment. And I think if this pans out, it will be really interesting. And just full disclosure, we were involved in the phase 2 trial in diabetes. We entered a few patients in Edmonton. The results are coming out for publication very shortly on pirenzepine, but it'll take a phase 3 trial to show it's safe and effective. Well, it takes a lot of people. This was the group at the Hotchkiss Brain Institute we worked with. I won't name them all, but some are neurologists now, some are critical care neurologists. Great bunch. Some have gone to different parts of the world, Boston and Japan, University of Saskatchewan. And here we are back in Edmonton, hanging out at White Avenue with the group. Again, great colleagues. But, you know, they need encouragement. And I think they get inspiration from knowing that there is a Calgary Neuropathy Association, and that this is very, very meaningful for people. So what are my suggestions how to tackle neuropathies? Well, this is it. You're raising awareness, educate the public. Government's here. They know about the problem. They've had personal experience, which is incredibly important. So elect MLAs and politicians to understand the stakes. And I've had a really nice relationship with my MLA in Edmonton as well, who gets it. There's some groups that are advocating for better brain and nerve health nationally. I've been involved with the Canadian Association of Neuroscience advocating for a better funding of the agencies we already have, but just fund them properly so we can do the work. There's something called the Canada Brain Research Strategy that's asking government to really make a major investment, a moonshot investment, like AI, into neurosciences to make it work. And then there's the Coalition of Neurological Charities, and I think the CNA can connect and may have already in the past. This is what supports research, but you know, 88% of people who spend months writing these grants don't get any support at all. And so the funding rate with CIHR, which the budget hasn't improved very much over many years, has really blocked advancements in research, and we think it needs to be doubled. And finally, neuropathy research will benefit from all areas. I mean, we learn things from chemists, from oncologists in particular. Some of these molecules, the oncologists understand, from chemists, from physicists, and many other forms of research. So I think raising the research bar is going to help this field, but also help a lot of other areas as well. So thank you again for inviting me, and it's been a privilege to work with the CNA.